Good morning, everyone. This is Professor Denham, and I'm going just to go over a few things with you, as I know you've been studying very hard for your next exam, and you've done the PNR 203 study concepts that was given to you, and you have reviewed exam number 3 prep, and you have reviewed mine. So I come to the conclusion that there's a couple areas that are a little bit weak. And so therefore, I just want to go over a couple things with you so that, you have a clear understanding. Because not only will you probably see this on exam number 3, but you also probably will see it on HESI. All right, so if you want to go open chapter 14 in your textbook, and let's go over the newborn with a perinatal injury or congenital malformation. And again, the key terms are right there for you, and they would be birth defects, cleft lip, cleft palate, achilioplasty, that's the repair of the cleft lip. Then you have clubfoot, congenital malformations, erythroblastosis fetalis, and habituation, hydrocephalus, hyperbilirubinemia, connectorus, macrosomic, meconium aspiration syndrome. These are terms that you have heard now for several weeks, actually, as we discussed them with other chapters. Then you have meningeal seal, meningeal myelocele, neonatal absence syndrome, the Ortolani sign, and then you have the Plavix harness. So we talked about when these babies have hip dysplasia and they have to be abducted into a certain position and kept there. So they have to have a little harness in order that they don't move out of that position. And then you have phototherapy, which is treatment for jaundice. And then you have ROGAM, and the shunt is for the hydrocephalus baby that has too much of increased cerebral spinal fluid. So, and then you have the spica cast, the spina bifida, and transient tachypnea of the newborn, which we call TTN, and then you have transillumination. So by now, those should be like flowing off your tongue because you read the chapters and you have attended exam reviews. So what I want to just go over with you is what we call classification of birth defects, and fall into some categories, and the first category is structural defects, and that would be your hydrocephalus or your spina bifida, because then what happens, and of course congenital heart malformations, cleft lip and cleft palate, the club foot, and developmental hip dysplasia, and tracheoesophageal fistula, and hypospadias, and others. So those go under structural defects that this baby's born with. And then you have some metabolic. And what we mean by metabolic is chemistry problems. And so you have cystic fibrosis, phenylketonuria, PKU, Tay-Sachs, that's a genetic disorder that's mostly found in the families of the Jewish religion. So these are things that would go under body chemistry. The maple syrup, I believe, would go under there. Okay, then you have blood disorders. So you have sickle cell disease, a hemophilia, thalassemia, defects of the white blood cells, the immune defense, and then others. Then you have chromosomal anomalies, and there's where you come in with your Down syndrome, and your trisomies 13 and 18. All right, and then you have perinatal injury, which is infections, and you have drugs, and you have maternal disorders, and abnormalities unique to pregnancy, such as RH disease, and difficulty of labor and birth, traumatic births, and precipitous deliveries, labor and delivery. So those are classifications of birth defects. So what you want to do is just write them down, and then underneath each one, what's the main thing you probably should remember? Okay, and so we're gonna start out with the neural tube defects, and the reason and some of this, when I say you may see it again, please take note to it. Okay, so we got neural tube defects. These are often caused by failure of the neural tube closure at either the cranial, which is your top, or the caudal, which is your lower end of your spinal cord. Now, so what can patient take prior to getting pregnant to help with not have these open neural tube defects would be folic acid. Okay, so let's go with the first one. That's hydrocephalus. And hydro means what? Water. And cephalon means head. So in the newborn, it's a condition characterized by increase of cerebral spinal fluid, increase in cerebral spinal fluid. And where it happens is within the ventricles of the brain. So right about the side of the head here, you have this big old ventricle, and that's where the fluid is not being reabsorbed. So what happens is the head gets really, really big. Okay, and so you have to worry about injury big time with this kind of baby. Okay, so what's the nursing care you think with this? Well, the nursing care would be to support the head. Okay, that's the main thing, because the physician, the surgeon, is going to put in the shunt, and so your nursing care would be to make sure that nothing happens to this really heavy head. Okay, and so we want to go ahead and support the head at all times, and then also during feedings, we want to make sure that we support the head. Okay, so what happens when you have increased intracranial pressure, guys? So what happens is that this increased pressure in the head causes your increased blood pressure. Now, just think about that. Now, let's not just memorize things, because when you memorize things, it just comes and goes. You don't retain it. So just think of an adult or yourself. When your blood pressure's up, don't you get this like increase in your head, like pressure in your head, like a headache? Well, that's what this is. So it's increased blood pressure due to increased intracranial pressure. If your blood pressure is going up, what's going down? Because the heart is really working. It's just not working properly. So you have a decrease in pulse, and then you have a decrease in respirations. And with children, you have this high pitched cry, and then their pupils could be unequal pupil size. When you see these TV shows and they're always looking at the pupils. Well, that's what they're looking for. They're looking for pupil size. And with increased intracranial pressure, you're going to have, guys, bulging fontanelles. Bulging fontanelles. Yeah, the fontanelles, remember, the interior and the posterior, and the interior is a diamond shape, and that would be bulging. Okay, and then you have headaches, and of course, and then you have irritability or just being lethargic, and that's not a child, right? Okay, and then you would have vomiting, and you have poor feeding. Okay, so that's intracranial pressure, and again, bulging fontanelles, and then you have hydrocephalus. And hydrocephalus, again, I said before, is characterized by the increase in the cerebral spinal fluid within the ventricles of the brain. And what happens is because pressure changes in the brain, and increase in head size. Okay, and then it results from an imbalance between production and absorption of cerebral spinal fluid. Okay. So hydrocephalus. So if you saw on the test about hydrocephalus, what would you maybe think a question could be? And a question could be, what's the nurse's priority when keeping the child safe with hydrocephalus? And again, is support the head. Okay, so that is, we're on chapter 14 for those who just came in. And you have to be always aware that something can happen with the shunt, okay? So the shunt goes from the ventricle in the brain, and it goes like down below, behind the ear and down into the peritoneal cavity. And so we have to worry about infection all the time because that's what can happen. Alrighty. So what's your treatment going to be? It would be they have to have a shunt put in. And these kids are in and out of the hospital quite a bit. Okay, so let's go ahead and go over some classic signs of manifestations of hydrocephalus, just in case you see this again. So again, classic signs would be increase in size of head, cranial sutures, they separate to accommodate this enlarging mass. The scalp is shining because it's being stretched and the veins are dilated. So again, we talked about the shunt being the main opportunist area for infection. So let's go over what's your nursing care going to be. So those are always good questions. So preoperative care would be frequent head position changes. Now, I've said that a couple times already, but it's true. And the reason why you want frequent head position changes is to prevent skin breakdown. So the head must be always supported. And I said head must be always supported at all times when being fed. And then nursing, you would, in your vital signs, you would include measuring the head circumference. Now, post-operatively, okay, so again, post-operatively, just like any other surgery, you're going to assess for signs of increased intracranial pressure. Protect for infection, that's the main one that we do on all our surgery patients. And you might have a surgeon might give an order as to how many times the shunt needs to be what we call pumped, okay, P-U-M-P. And then position, you're going to always change position. It depends upon, the baby and the surgeon too. And then assess and provide for pain control. Yeah, do these babies have pain? Yes, they do. And so we went ahead and make sure. Now, patient education, we want to teach signs that indicate shunt malformation, and again, how to pump. And these are what we're going to teach the parents. Okay, now, do you think the parents would be afraid to take these children home? Yeah, I don't blame them. And so we want to make sure that from the time the baby comes out post-operatively, that the parents are being educated on how to pump the shunt. Okay, then signs of shunt malformation in an older child may have headaches. Yeah, because if it's not draining properly, then the pressure fills up, cerebrospinal fluid pressure fills up in the head. And then you may have lethargic and changes in level of consciousness. Okay, so that's on hydrocephalus. And I know I'm going to give you a hint. I know you'll see it again. So that's why I went over it. Another area that you might see again too is spina bifida. All right, and in the beginning, I talked about prevention of spina bifida. Yeah, have a woman before she gets pregnant, get on folic acid. And I tell you what, it's the best thing that could happen. There's been a lot of research on this over the years, and I have seen this just evolve. Okay, so when you have a baby with spina bifida, and you have a sac that's outside, let me refer you to a page in your textbook that I just love because it just gives you a really good visual. It's on page 332. And you can see the difference between the occulta, and then you have the one that has the cyst, and then you have the whole one that has the whole sac, meningeal, myelocele. You see the whole thing coming out. Now, by just looking at these drawings, especially on B and C, you can see how you would have to protect that sac. Okay, so what are you going to do? Well, you're going to make sure that you put a sterile towel with sterile saline on it, so that you keep it moist. Okay, that's the main thing. You don't want to ever dry out an organ, because then if you dry it out, it dies, and we don't want to do that. Okay, so we want to make sure that we protect the sac and make sure the baby's not laying on his back, because that would hurt the sac. Okay, and just a note that we talked about prevention, treatment. Well, the treatment depends upon the type of spinal bifida it is and how extensive it is. Okay, but these babies are disabled, guys, from birth. They have trouble with incontinence of urine and feces, and so sometimes we have to make the most. So instead of rehabilitation, they go to what we call habilitation, and what we do there is, we want to have methods to help assist parents and child in developing a healthy personality. This is really, really tough, and we always want to minimize the child's disability. So what we do is we focus on all the unaffected parts of the body. And then every effort is made to help this child develop into a healthy personality, so that he or she may experience a healthy and productive life. Yeah, it's really difficult on these parents, and not only for the child, but of course for the parents. And so, again, nursing care, we want to make sure that the main objective of nursing care is to include prevention of infection or injury to the sac. So how you do that is by correct positioning to prevent pressure on the sac and the development of contractures. And so, you have exercises. Again, I said to constructively use all the unaffected parts. Okay, so that's spina bifida in a nutshell. And we're going to move on to the next one, and that's called the cleft lip. And what happens there is you have an opening. So it's characterized by a fissure or opening in the upper lip. So what happens is that during the embryonic developmental stage, the maxillary in the median nasal process that unites, it didn't happen. Okay. So unfortunately, some of these are hereditary, and some could be a product of the environment. The sooner they can do this kind of surgery, probably the better. And the main thing is that they are kept free of infection. They're going to go ahead and do a surgical repair. And the cleft lip is repaired before the child becomes 6 months. Okay, and again, the child must be free of infection. So these children, if you think about it, don't have the ability to suck. So you have to worry about nutrition on the cleft lip and the cleft palate. And surgery, it not only improves the infant's ability to suck, but also greatly improves the appearance. And therefore, it does influence bonding and the amount of affection the infant receives. Because I'm going to tell you, some parents, because they don't have a perfect baby, kind of refrain from actually cuddling their babies. Okay. All right. Now, so we talked about the treatment is surgery, and that surgery is chelioplasty, which is spelled CHEILOPLASTY. And that's in your book on page 335. So now, sometimes, and I said about they should be repaired like before age 6 months. Sometimes it's all according to the doctor. Now, infants may have to they after surgery, they have to be kept from what? Scratching. Yeah, scratching the lips. So unfortunately, you may have to do an elbow restraint because you want that surgical incision on the lip to repair, to come together really nice. Because when a child has a cleft lip, that there is a scar in the front, and that can really affect this child forever. So you want to make sure that the child is kept free from infection and he does not scratch the lip. Now you may see that again. And then another thing, very important, is we got to feed this child. So a special syringe or bottle must be used in order to assist feeding the child until surgery has occurred. Okay, so is it hard on the parents? Yes, it is. Because again, I told you that some parents don't even cuddle with their children. All right, so we want to make sure that they get they get the proper bonding. And that's where us nurses sometimes come in handy. It's because we do that. Okay, another thing we're going to talk about now, I believe, is the cleft palate. Now you probably see this again, and I think it was on your quiz, that what condition is commonly associated with an inflammatory cleft palate? Well, when you have this passageway between the nasal pharynx and the nose, so all this in here, and it's open, okay, because it didn't develop, it didn't fuse. It developed, but it didn't fuse during the 7 to 12 week of gestation. So you have that open. What do you think this child is more prone to? And that would be infections of the respiratory tract and ear infections. Sure, absolutely. So I think you'll see that one again. So take note to that, please. So what's your goal of treatment? Well, the goals of therapy is what? To close it. Yeah, we want to close that up, improve feeding, improve speech. Absolutely. And then, of course, what's all involved in the mouth is the dental development. Okay. And so these children may have problems with their teeth. And then again, the nurturing of a positive self-image, you better believe it. Okay. So what's your nursing care of the child with a cleft palate? Well, you got to prevent them post-operatively. Nursing care post-operatively. So write this down. And so number one is always prevent infection. Okay, prevent infection. And then prevent that infant from sucking and crying. Now, this is what you have to do. Now, is that hard to do? You better believe it is. Because children are going to be in pain, these babies, so they're going to want to cry. And so you want to prevent them from sucking and from crying. And then careful position to avoid injury to the operative site. Oh, and then, of course, I said about preventing infection. And prevent infection and scarring. Yeah, by gently cleansing the suture lines. And what you want to prevent on this baby is to prevent those crusts from forming. So you have to wash the mouth out. And then provide for the infant's emotional needs by cuddling. We talked about that. And provide appropriate pain relief. Yeah. Not easy. It's not easy on parents either. Now, post-operative treatment and nursing care, nutrition. Okay. So the diet is progressively advanced as we can. Now, if you're using a straw, you do not use straws. Write this down. Do not use a straw. Right? Give any foods through a straw because you have to prevent sucking. Okay. And then we talked about oral hygiene, keeping the mouth clear, cleanse it with some clear water after eating, and then speech. And speech is hard. Because if you didn't have, if you have a cleft palate, you need all that formation in your mouth to make words. And so when you can't do that, you have a problem. So we want to encourage these children to talk. So talk to them. Okay. Again, post-operative treatment and nursing care falls under ear infections and tooth decay. So we must always be prepared for that. Okay, so we're going to go on now to club foot. And it unfortunately it does happen. And it is the foot twists inward and outward. It generally involves both feet. And the child walks on his toes and other borders. Now, what's your nursing? What's your treatment and nursing care? Well, this is what you got to do. You start as soon as possible, or the bones and muscles will continue to develop in an abnormal manner. So you see, they're going to be little when you start treatment on them, because children grow fast and their bones grow fast and their muscles. So you can't, if you don't do anything, they will continue to grow in an abnormal manner. So sometimes you can choose like a conservative treatment first. And conservative, I talk about like putting a cast on the leg or splinting to hold the foot in a correct position. And then sometimes using passive stretching exercises, stretch those muscles and those bones to where they should be. But if it doesn't work, and you give it about 3 months, surgical intervention has to be done. And that does work. Okay. And when you have a cast on anybody, you have to make sure that the toes are exposed so that you can check on circulation, because we do not want this child to lose his legs. Okay, parent education. Well, you have to stress the importance of complying with the physician order to prevent skin breakdown. And what happens is that these children go in quite a bit because they're growing. So they have to have updated casts, and you have to give them ultimate cast care, and then you have to have emotional support. Okay, so that is on hip. We're going to go into now. That was on club foot, and now we're going to go into hip dysplasia. Okay. So what happens is that hip dysplasia applies to various degrees of deformities. So you can have like subluxation or dislocation. That means it can be partial or complete. What happens is the head of the femur is partly or completely displaced. So the acetabulum, where it should be nice and deep, okay, it's not. Okay, so therefore the head can't fit in, right? Cannot fit in nicely. So what happens is that you get not a symmetrical, but a non-symmetrical, uneven folds in the baby's buttocks. Okay, and it appears apparent in infants and toddlers as they become walking. But the pediatricians are really good about looking at babies in the nursery, and they'll take the baby and they'll actually hold the baby and see, and they can see if there's a difference in the gluteal folds in the buttocks. And let me tell you, on page 338, you can see that it's not symmetrical. Remember, what's on one side must be on the other side, so they must be even. When they're not even, see my hands are not even, then you can have this hip dysplasia. So there's 2 kinds of tests. One is called the Barlow test. And this is when you have an adduction, an extension of the hips. Okay, so the healthcare providing stabilization of the pelvis, and they may feel this location actually occur. Okay, and then my favorite one is called the Ortolani sign, because I can hear it. It's actually a click. And we can actually feel and hear the femoral head slip back into the acetabulum under gentle pressure. Okay, so that's what I talked about before. So that's called the Ortolani sign. Now, how are you going to treat this? All right, well, got to keep the hips in constant flexion and abduction of 4 to 8 weeks. Is constant pressure enlarges and deepens what? That acembellum. Okay. And so it makes it deeper so that the head of the femur can go in there. It kind of makes sense. So what do you want to do? Well, how are you going to keep a baby in this kind of position? Think about it. Okay. And so it's not easy. So you have to put him in what we call a pelvic harness. And that actually provides the necessary positioning. And, surgical intervention is there, may be necessary. So nursing care, well, we want to, it depends upon, of course, the condition and what the depth is. But we always want to make sure the infant is prone, and the nurse observes the buttocks for variation in size, and the legs of the infant should be equal in length when you're in this little harness. And then the infant should be kicking with both legs, not just one leg. Okay. Now the depth and the number of skin folds on the infant's upper thighs, again, like I said, should be symmetrical. All righty. Not easy when you have an infant in either a cast or a pelvic harness. But let me see here. Give you an idea of a question. Let's see if I can find an old question on this. Give me a few seconds here. If you had a question that it said that the gluteal fold is higher on one side than the other, what condition would that be? Okay, I just went over that. That would be what? Developmental hip dysplasia, because again, it's not symmetrical. Okay. Spina bifida we talked about, that's when the meningeal myocele is outside the spinal cord. Down syndrome, it is what? Trisomies, it's the mental challenge children, is just not symmetrical, nothing to do with gluteal folds. That's the thing. And then a club foot, we talked about that. That's nothing to do with folds of the gluteal. When you see that, that should ring a bell, and you should say hip dysplasia. Okay. When you're answering on a test, answer these questions, be sure to read the question fully and ask yourself, what's the question asking me? It does work. All right. Let's move on to metabolic defects. Okay, so these are what happens is there is an error in metabolism, and so it involves a genetic defect that unfortunately that may not be apparent until after birth. We can see this type of birth defect on ultrasound. No, so these are things that can happen. So if a child is lethargic or a poor feeder, children, they shouldn't be poor feeders. Children like to eat. Hypotonia, that's very low tone. The unique odor to body or urine. Absolutely. What was that one we talked about already? That maple syrup. It's a really sweet odor. That's not normal. Then you have tachypnea and you have vomiting. These are all symptoms that you need to report. And these are all errors of metabolism. Usually what we see is that when a baby is a poor feeder, the mother presents to the pediatrician office pretty quick because the baby's not eating, and babies should eat. Okay. And then again, another one, that's unique odor to either body or urine. Okay. So I'm going to talk about PKU, because what happens is a faulty metabolism of the fetal phyline. And phenolphthalein is an amino acid that's essential, vital to life, and is found in all protein foods. So the infant is unable to digest this essential vital acid. And so what happens is then the fetal thylline accumulates in blood and is found in the urine within the first week of life. That's pretty quick. So let me go over that one more time. This infant is unable to digest this essential acid, and fetal thylline accumulates in his blood and is found in the urine within the first week of life. So that's why before the infant leaves the hospital, we're going to do a PKU test. Because what happens if that the baby is positive for PKU, it can result in severe mental retardation if it's not caught early. So we want to catch every baby, don't we? Sure. Okay. So what's your nursing care? Well, you have to teach parents the importance of reading food labels and following up as required with healthcare provider for blood tests. Okay, and you refer to a dietitian is very helpful in providing parental guidance and support if the child does test positive for PKU. And of course, genetic counseling may also be there. Okay, so is it hard? Yes, it sure is hard. Okay, so I want to refer to you to page 341 in your textbook, and it goes over PKU. And these children are not able to take in protein. So they can't breastfeed, and they have to have a special substitute for the milk. And that is one of them I'm very familiar with is a formula. It's called lofenalac, and that's spelled LOFENALAC. Oh, there's another one too, spelled excuse me, PHENEX-1. Now, again, these are free of any kind of protein, and so therefore, children can get fed, but without accumulating the fetal thylline, or keep it at a very low content. Okay. Now, your book does say there is a low fetal thylline content in breast milk. So the infants can be partially breastfed and supplement with lofenalac. But what happens, I'm going to tell you the truth, once you start supplementing with the bottle, the baby's going to go for the bottle. Okay, I just wanted you to know that. And again, we've talked about genetic counseling. It's important for the affected child, for future family planning. And women of childbearing age who have PKU, they must follow low fetal thylline diet before conception to prevent brain damage to the fetus during development. All right, so that's PKU. And the test, let me tell you, the test that they use is called the Guthrie test, and that's spelled G-U-T-H-R-I-E. If we just take a few drops of the capillary blood and we put it on a filter paper, and then we send it to the lab, specialized lab, and you have to have those little drops of blood in that little circle, otherwise it's no good. Okay, it's a very specialized test. All right, so that's PKU, and the next one we're going to go over is maple syrup urine disease. And we kind of talked about that a little bit, because that's where the urine is has a very, very unusual sweet aroma, like maple syrup, like you put on your pancakes. That's how I kind of remembered it. It's just real sweet. So what happens, there is a defect in metabolism of, again, the branched chain amino acids, and it causes marked serum elevations. And that's three types. It's called leucine, L-E-U-C-I-N-E, or ISO, I-S-O leucine, L-E-U-C-I-N-E. And the last one is valine, or valine, I should say, V-A-L-I-N-E. Well, the main thing about that, it does result in acidosis and cerebral degeneration and death within 2 weeks if not treated. So is it pretty severe? Yeah, it is, and the metabolism, and it's sad too for moms. Okay, so what's your treatment going to be? Well, let's remove those amino acids, right, and their metabolites from the body tissues. So what happens, you have to do massive hydration, and they have to have dialysis, peritoneal dialysis, to decrease this amount of leucine or isoleucine of valine in the blood. Okay, so it's a lifelong diet that they have to follow, in low in amino acids, low in leucine, isoleucine, and valine. It's a lifelong, just like PKU is lifelong. Okay, and sometimes questions, and sometimes HESI will put that kind of question on about lifelong. Yes, it is. Okay, they're born with this, and it's an error in the metabolism of these amino acids. And if you go back to your science classes, you know how important amino acids are. So this is pretty bad. And they can have, outbreaks, and if they get too much. And I tell you, it can be life-threatening, and it can be infection can be life-threatening to these kids. Not good. Okay, so if you want to read more about maple syrup urine disease, it's right on 341, and it goes over pretty nicely. The next one is glycosemia, and what it is the body is unable to use the carbohydrates, glucose and lactose, sugars. So in the healthy person, the liver converts the glucose to glucose. In the patient with glycosemia, which is too much in the blood, it's an enzyme is defective. The enzyme is defective or missing, and therefore there's a disturbance in the normally occurring chemical reaction. So their body is not able to use that glucose or lactose. Okay, so it results in an amount of glucose increase, a lot of glucose in the blood and in the urine. So you have glycosemia, which is in the blood, increased amount of glucose in the blood, and then you have also glycosuria, which is an abnormal amount of sugar in the urine. Okay, so this can cause cirrhosis of the liver. And how about this? Cataracts and intelligent impairment if left untreated. Now, because lactose, if you think about it, is present in milk sugars, early diagnosis is necessary so that a milk substitute can be used. Okay, so early, put it this way, for this kind of problem, where you don't have the enzyme that's needed to help the liver convert glucose to glucose, is missing. So early diagnosis is essential. Absolutely. Okay. All right. So what's your nursing treatment? Well, take away the milk and the lactose containing products. Take them out of the diet. On this one, it does say breastfeeding must be stopped. Okay. And they have to use lactose-free formulas or soy protein-based formulas. And then, parents, they need a lot of support and education. Yeah, it's scary to them too that the baby doesn't have the enzyme it needs to break down the glucose and lactose. All right. So moving right along, we're going to go into the area called chromosomal anomalies. And this is the first one we're going to talk about is Down syndrome. Okay. So what you need to know about Down syndrome is that it's the most common chromosomal anomaly. What happens is mommies are AMA, advanced maternal age, and so mothers are like 35 and above. They're more prone to it. Fathers, 55 and older, and then there's all different types, all different levels. And so what happens is that what we do is we do that alpha-fetoprotein test, and if that comes back irregular, then, and it gives a really nice breakdown, then what we do is we have to follow up with an amniocentesis. Now, we don't make um, we don't end a pregnancy based on an alpha fetal protein test. No, no, no. Because some of those tests, those parameters, they have to be so exact. And so what happens is you could have a false positive. So that would be terrible. So then what we do is we suggest an amniocentesis. Now write that down because I think you're going to see that one again. And so, and what happens with an amniocentesis, we're taking out what? The amniotic fluid. And then they do a beautiful workup of the chromosomes and they analyze them. And they line them up. And so remember the chromosomes, what should have, they should be in pairs, right? 2. And so if there's an extra one, and it's a trisomy, because 3, tri. So you are then given the more exact, more exact result. Okay, so I'd like you to look on page 343, and you can see this child, little baby, with the typical facial appearance of an infant with Down syndrome. Okay, so you see his little eyes, and how they have the little canthal folds of the eyes. And then on a big one, I've seen this on a HESI question, they have a protruding tongue, and they have a short, thick neck. Okay, and then again, too, you might see, you can tell when a baby's born by looking at his hand. And you can see that what? Simian crease. And it goes right across the, the palm of the hand. Okay, now you'll see that again. All righty. So what happens is these developmental milestones are a little different in the Down syndrome baby versus the normal children. And on your page 343, it's a nice table. It's called table 14.1. That is a nice little thing to know. Okay, because if you have a mom who's concerned that her baby, you know, and he's Down syndrome, and his baby, maybe the baby is not doing like he should, and he's real slower, just say he'll catch up. Okay, this is just typical of a child born with Down syndrome. All right, do parents need support? Yes. I had a parent in the delivery room that was so devastated because when the baby was born, we could see the child's face that he just wasn't normal. Okay, it's very sad. And I looked at his little hand, and there was that simian crease right across the palm of the hand, and it's just a straight line. And that was the first thing. And of course, his neck, he really didn't have a neck, and his low set ears were there. And so my mom was just taken back. She had no idea. This was before our alpha fetal protein test, and she wouldn't have anything to do with the baby. She gave the baby up. So yes, it is very, very sad, and parents need to know that, you know, okay, you have a baby born with Down syndrome, but there's lots of things that we can do today. Absolutely. Okay, we're going to move right along and go into the hematologic disease of the newborn. And I know you've heard this because I said it way back. We talked about Rh negative, and mommy being Rh negative and babies being Rh positive. Okay, so it's called erythroblastosis fetalis. And I bet you said that at a Christmas party, you would get people's attention and they go, oh, wow, she sounds really great. But anyway, it is a pretty serious problem. And I said because Rh negative mommies and Rh positive daddy produces what? An Rh positive fetus. So even though maternal fetal blood do not mix during pregnancy, okay, small leaks may allow fetal blood to enter the maternal circulation and causing the mommy's blood to start producing what? Antibodies. Remember we talked about a little Miss Pac-Man? Okay. And these little antibodies cross the placenta and destroy the blood cells of the fetus, the erythrocytes, which causes baby to be what? Anemic. And then and also baby can have heart failure. And so this is a pretty serious situation. So remember, baby has all nice circulating erythrocytes, okay? And mommy is what? Here's, watch my hands, and here's like Miss Pac-Man. So here's her blood. Now, what happens is they have a little mixture, and they shouldn't, but it can seep in. So these little antibodies, mama go, whoa, what's happening here, right? So mommy's body starts to produce antibodies that crosses placenta, like everything else does, and destroy the blood cells, the erythrocytes of the fetus. And so then baby goes, wait a minute. And he starts to, his blood starts to dwindle down, right? The amount of blood circulating in his body, and he becomes very anemic. And now his little heart needs red blood cells, just like all of us, we need red blood cells. So what happens? You can have heart failure. So what we're going to do? How we're going to prevent erythroblastosis fetalis? By the use of Rogaine. Now another term, and I know Hesse likes this term, is called RHD immune globulin. RH, and then it has in parentheses D immune globulin. And I've seen that where they actually use that instead, that term instead of Rogaine. Okay. So that's what that's all about. And then you can do 2 tests. You got the direct Kuhn's and you got indirect. Now the direct Kuhn's test is on the umbilical cord blood. Okay. So symptoms. Well, symptoms may vary, but we talked about anemia. It's caused by the hemolysis, which is the little Pac-Man gonna eat you up, and a large number of baby's red blood cells or erythrocytes. Now, baby can have pathological jaundice, and this occurs within 24 hours of delivery. Now, write that down because that's a pretty important one. It's called pathological jaundice, and put it down. Pathological jaundice occurs within the first 24 hours of birth. Well, it's really bad. Anything that's called pathological, you can always think is bad, okay, because there's a pathology behind it. There's a reason. So what happens, the liver cannot handle the amount of the destruction of red blood cells. It cannot handle the amount of hemolysis. So then what happens, your bilirubin levels, they go up very quickly. Okay. So it's never good. All right. So enlargement, so what happens is that you have enlargement of liver and spleen. All right. So, and because your oxygenating carrying capacity of blood is diminished, it includes blood volume. All right. So these infants are a major risk of shock or heart failure. That's why we have to be on top of this condition and make sure. Okay, now another, because there's another term too, that when bilirubin has reached toxic levels, that's called kernicterus. And that was one of your key terms. That's KERNICTERUS. That's bilirubin that has reached toxic levels. And when bilirubin gets accumulated in the brain, it can cause serious brain damage and permanent disability. So we want to make sure that we're on top of those kind of things. Okay, so that's another term that you probably want to look up a little bit more. All right, so what are you going to do? You have a little treatment. So what's your treatment for erythroblastoma fetalis? Well, one, prompt identification. Yeah, these babies, they get that jaundice in the first 24 hours. You know that that's not right. Okay, that means that's an indication. Let me tell you, that's an indication that the liver's not working. Okay, so what are you going to do? Well, I would get my laboratory test. All right, call doc and say, we got a problem here. And this baby is, I see, first signs of jaundice. And it's baby's just a few hours old or maybe 18 hours old, doc. He says, okay. So then we know we're dealing with something pathological. So we'll get liver enzymes on this baby, and you'll see the liver enzymes be elevated. And then may have to give them some drugs, and then phototherapy. Yeah, phototherapy using ultraviolet light. And sometimes when real bad, hold on, everybody, excuse me. Excuse me. Sometimes when it's really, really bad, they have to do exchange transfusions. And I tell you, when it's really, really bad, and baby's in utero, sometimes they do, I'm going to tell you, intrauterine transfusions. Okay, so that was about photo. And then let me go over some nursing care phototherapy before we go on, because you really have to know this. The baby's under ultraviolet light. So the main thing you want to do is, baby's like an incubator, because you're going to have him totally naked, maybe a little diaper, just so that he has any kind of secretions, like feces or urine, you catch it. But he's under the ultraviolet light. These are really bright lights. You have to put eye patches on them, okay? And it's like, remember you go out to in the sun on the beach, and you don't sit in the sun looking at the sun. Now, looking at the sun without sunglasses, you couldn't. You're going to burn your eyes. So we don't want that to happen to these babies. So we're going to put a little patch on their face. Now these babies, they're not going to like it. They know something's there. They go, what the heck is this? And so they'll squirm and move, and you have to watch them. Now, hydration, we're going to be giving them hydration because we want them to excrete the excess bilirubin in the urine or the feces. Okay, so I'm going to make sure that it gets hydrated, and I'm going to make sure I move around, of course, to make sure their skin don't break down. And when they have excretions, I'm going to change their little underpad, make sure they're dry so there's no skin breakdown. And mommies have to be what? They have to be told, all about this, and they can go in there and see their baby. But the main thing is that the baby gets enough hydration to excrete this bilirubin. Okay, so that takes care of erythroblastosis totalis treatment. We're going to move right into intracranial hemorrhage. Well, this falls under what? Birth injury. All right. And just like you think, it probably from some kind of trauma or a lack of oxygen. And it occurs a lot in preterm infants. And it can occur when you have a precipitous delivery. And remember, the labor and birth is all within 3 hours. So you could have that. Or on the opposite, you could have intracranial pressure from a prolonged labor. And you go, well, how can that be? It's because the baby's head has been down in the birth canal for long time. And so you get this intracranial hemorrhage, a bleed right in the brain. And so therefore, it can happen. That's why you have to be very careful that you don't have your patient too long in labor or too short. Okay, so because things can affect the fetus very, very easily. Now, signs and symptoms of this really depend upon the severity of the damage to the head. Okay, so they're always going to have some poor muscle tone at birth, right? and may be lethargic. They may have a poor sucking reflex. And so you have to be well aware of this. And that's why when babies are born, if you're working mother-baby unit, you want to tell the nursery nurse what kind of delivery that you had. Okay. All righty. So I know that was kind of a short definition, but that's what happens with intracranial hemorrhage. You have these little bleeds into the head. And again, it's just, born just on the severity, it's based on the severity of it, but you don't want to have this intracranial hemorrhage. No. Okay, so let's go on. Let's see. How about transient tachypnea of the newborn, TTN? Well, just like it sounds like, you've got a baby that's breathing too fast, tachypnea. So what happens? Okay, so if you don't know the signs of a baby in respiratory distress, then write this down again, because you probably see it. And it's one of those questions that could be like all that apply. So you have tachypnea, you have what? Chest retractions. Remember I told you the sternal retractions? Okay. You have grunting. They make those terrible grunting. And then you have nasal flaring. So, and then the baby can have some kind of cyanosis, maybe mild, but it'd be more than just his hands and feet. It'd be his trunk has cyanotic. So, again, this is what we call respiratory stress. Okay, if you have a baby that's born to a mom who's got maybe amniotic fluid problems, she could have maybe meconium. So if you saw that the meconium at birth, then you would be very concerned if this baby starts having retractions, chest retractions, tachypnea, nasal flaring, grunting, because those are all signs of respiratory distress. Okay. All right, so please take note to that. All right. Now, usually this resolves after 3 days. Yeah. And what happens is that these babies have a lot of fluid. And so sometimes they have slow absorption of the fluid in the lungs after birth. So when they have this slow absorption, they can have this TTN. All right. Again, supportive care, nursing care, support from the nurse to the parents. And maybe baby's got to go into the NICU, especially if you've got meconium stained fluid. Because what am I worried about? Meconium aspiration syndrome. All right. Well, here, now the next thing in your book is meconium aspiration syndrome. And we all want to know what that is, but I'm going to go over it again. And that happens, it happens in utero, where the baby expels meconium into the amniotic fluid. Now, also, there could be oleohydramnios, so you could have cord compression that interrupts cord or fetal circulation. Okay, and we don't want this to happen because these babies can get asphyxiated, or worse, they get acidotic. And so they may have some gasping movements that causes meconium stained amniotic fluid to be drawn into the lungs. Not a good thing. All right, so at delivery, what are you going to do? Well, remember, we're going to, when the head pops out, we're going to have deep suctioning from the wall suctioning. And we don't stimulate these babies to cry. No, they go right over to the radium warmer. Okay, and then we'll have respiratory therapy in there, and they'll intubate the baby and go deeper. Okay, so we try all we can to get this meconium out because we're afraid of the respiratory distress resulting from meconium aspiration syndrome. All right. Okay, so take note to what I just said. All right. Now, neonatal absence syndrome. Okay, so it was on your quiz, so be sure that you go over this. Okay. But what happens is the fetus is exposed to what? Drugs in utero. Okay, so again, many illicit drugs cross the placenta barrier, and therefore an infant born to a woman who's addicted will suffer a drug withdrawal at birth, after birth. Yeah, you get fed, these infants are getting fed through mom taking it in, it crosses the placenta, baby gets it, right? So now the baby has it and it builds up in his system, and because remember, he doesn't have the ability to break down these drugs like you and I do. And so therefore what happens, he gets a buildup. Okay, so if a baby is hyper irritable and has tremors, it has difficulty feeding, and it has like yawning a lot. What condition would this baby have? It would have neonatal absence syndrome. Okay. So body tremors and hyperirritability are the principal signs of this condition in the newborn. Now, wakefulness, diarrhea, poor feeding, sneezing, and yawning can also be present. So what's the treatment for neonatal absence syndrome? It would include providing a quiet environment with swaddling to reduce and reduction of external stimuli. Now you have to watch these babies close for seizures. Now I'm going to tell you something, and write this down, that the American Academy of Pediatrics supports the treatment of the mother with methadone during breastfeeding. Okay, I could see that being a big question on HESI. All right, so that's neonatal absence syndrome in a nutshell. All righty, infants of diabetic mummies. All righty, well, if you notice that a newborn is large for gestational age, what condition is most likely to be a contributing factor? Well, let's go over gestational diabetes. Okay, so what happens to these babies? Well, what causes them to be big would be large amounts of glucose are transferred right to the fetus. It causes the fetus to become hyperglycemic, and the fetal pancreas then produces what? A large amount of fetal insulin. Sure. And that leads to what? Hyperinsulinemia, which leads to a lot of insulin being produced. And along with that, you get excess amount of what? Protein and fatty acids. And when that all comes together, you have a LGA baby, which is a large gestational age. And these babies weigh like, greater than what? 4,000 grams or 9 pounds, or we call them macrosomic babies. Now, the diabetes in the mom, they produces a lot of different problems for a newborn. So these are determined by the severity and duration of the mother's disease, the degree of control of mom's condition, and the infant's gestational age. Now, when mom's diabetes is under control, good control, from conception and throughout the pregnancy, the adverse effects on a newborn infant are what? Are kept down. Okay. Many newborn infants of diabetic moms do have serious complications. When the mom is hyperglycemic, she's got too much blood sugar, then large amounts of glucose is transferred to the fetus. This makes the fetus hyperglycemic. And like I just said, the fetal pancreas, which is your isolate cells, produce large amounts of fetal insulin. Then you got this large amount of insulin along with excessive production of protein and fatty acids. So I just said that. Okay, so now you can see why these babies would be what we call that term macrosomic. All right. Okay, so a typical macrosomic baby is on page 351. And you can see that big baby. Yeah, hopefully that big baby was born by cesarean. Otherwise, these kind of babies, when they're born vaginally, mom ends up with a 4th degree episiotomy. She may have some other lacerations, and baby could have shoulder dystocia. So it's very hard for that to happen. Okay, so that was the end of chapter 14. Be sure that you read the key points, because this chapter was not that long, but it was an important chapter to know about the injuries that can happen at birth and some of the complications that can happen. All right. Let me go on, and we're going to touch on a little bit on chapter 13. All right, give me just 1 second here. And now chapter 13 is on the preterm and post-term infant. Now, we already talked about the term infant, and these babies with preemie, they have their own problems, you know? I mean, they're born a little bit too soon. It's not a long chapter. Let me just get to that chapter here. It's not a long chapter. No, not at all. And so let's try to organize our thought process on this. So we all know what preterm is. So we don't I won't have to review that because we already done that. But just to let you know that preterm birth is a cause of more deaths during the first year of life than any other single factor. So should it be taken serious? Oh, yes. It has a higher percentage of birth defects. And so we want to, make sure that we understand these definitions from the American College of Obstetrician and Gynecologists. So that means that gestational age, so put that as a topic, gestational age. Because you have others, you have chronological ages, you have gestational age, but I'm just going right now over what? Gestational age. Okay, so preterm infant is less than 37 weeks. Okay. The early term infant is between 37 weeks and 0 days and 38 weeks and 6 days. When how we write that is 38 and then 6/7. And then full term infant is what? Between 39 weeks and 40 weeks and 6 days. Okay. And then late term infant is between 41 weeks, 0 days, and 41 weeks and 6 days. Okay. Does that make sense? And then post-term infant is between 42 weeks and 0 days and beyond. That's what gets me sometimes, because I worked labor and delivery for so many years that when we have somebody at 42 weeks, we watched them like a hawk, because usually we ended up with an abnormal fetal heart rate tracing. Okay, so causes of preterm birth. Well, we have multiple births, multiple fetals, twins, triplets, quads, and on we go. Mom may be sick. She may have preeclampsia. These things cause preterm labor. Hazards may have gestational hypertension. I just said that. Placenta abnormalities, placenta previa, or abruptio placentae. These are things that once they happen, especially with the placenta previa, if they're bleeding a lot, we try to get them more days, make sure that we can, maybe every day is a gift. And when you're working with these kind of patients, every minute, actually. Anything can happen. And then you have a premature separation of the placenta from the uterine wall. That's your abruptio. That too. Once that happens, we can stop. No. So if you got a placenta previa that's bleeding, you can't stop her. No, you're gonna have to get this baby out. Abruptio, you have to get the baby out. Okay. Unfortunately, preemies are born with what? Low immune, a lot of immune problems. So they are at high risk for a infection in the bloodstream, which is called what? Septicemia. The liver is so immature. They have poor formations of antibodies. Yeah. And their body enzymes are inefficient. Yeah. It's not ready for them to be born. It's too early. They were supposed to be inside mom's natural incubator. What? For all this to keep what? Advancing. And when they're now outside and called extrauterine life, they're not ready for that. So they have low temperature. They're irritable and they're lethargic, poor feeders, and respiratory distress. Not good. So what are you going to do? Well, for treatment of sepsis, you're going to give these babies. These babies will be in your NICU. You have to give them IV antibiotics. You have to maintain warmth and nutrition and close monitoring of vital signs. The main thing about this, we call it like cluster care, is that care should be organized to help the infant conserve as much energy as possible. And always, you're going to follow standard precaution, which includes strict hand hygiene. Now you might see that again. So what kind of precautions are you going to use? Going to use standard precautions. Strict hand hygiene is essential. All right. Now these little preemies have a horrible time with their body temperature. Sure. It's hard enough on term baby, but when you have a pretermer, their core temperature can fall very fast. So what we want to do, we don't want to overcook them either. You have to be careful with these radiant warmers or incubators because you don't want to overcook the baby. So what would I do? I would put a skin probe. Yeah, and you put it in the right upper quadrant of the abdomen. And then you hook that probe up to the radiant warmer or the incubator, and it will keep the optimal body temperature for the infant. And that should be like 97.1 to 98.6. And, or if you're doing Celsius, it'd be 36.2 to 37. Okay, so that's on body temperature. Now these preemies have a hard time with what? Regulating their glucose. Oh yeah, they too. All right. So in a preemie, you could have a blood glucose level that's less than 30 milligrams per deciliter. Now remember, in a term infant, it was less than 40 or whatever book you're reading, or less than 45 milligrams per deciliter. Okay, but for a pretermer, it could be less than 30. And that you better be very careful about. So they have this increased need for glycogen in the brain and heart and other tissues. So they're not, if they're a preemie, they have not been in utero long enough to build up stores of glycogen and fat. All right. And then any condition that increases metabolism increases glucose need. Okay. And so energy for these babies, just living, just breathing, they need energy, and that puts more stress on the already low stores, deficient storage of glucose and fat. So we don't want them to be hypoglycemic. So what we're going to do, we're going to monitor their blood glucose and make sure that they don't get too low. All right. And then they might have another problem called hypocalcemia. That's hypo, and then it's calcemia, C like cat, ALCEMIA. What happens is calcium gets transported across the placenta in high quantities in what trimester? In the third trimester. So these little babies are born before the third trimester. They're going to have what we call early hypocalcemia, which occurs when the parathyroid fails to respond to the preterm infant's low calcium levels. Yeah, the parathyroid is immature. So it doesn't send the signal out that, hey, this baby needs what more. It's because it's just not gonna work. It's not working. So we got to keep an eye on this. Now, you may have what we call late hypocalcemia, and that occurs about 1 week in infants who are fed cow's milk because it increases the serum phosphate level, causing serum calcium levels to fall. Now, you may see that question again. All right, so you want to make sure that you know that, about hypocalcemia. And also infants who have that glycemia, like too much glucose in their blood. Cow's milk would be contraindicated. Okay, all right. And you probably want to know why that would be it. And so what happens is that in glycemia, the body is unable to use the carbohydrates, the glucose and glucose. Okay, we already talked about that. In a healthy person, the liver converts glucose to glucose. In a person that has glycemia, an enzyme is defective or missing, and therefore there's a disturbance. Okay, so cow's milk would be contraindicated when you're dealing with somebody with glycemia. Okay, and here it is too. You have late hypocalcemia that occurs 1 week in infants who are fed cow's milk. All right. I hope that you wrote that down, and if you need to, stop the video later and write that down. Okay, let's go on to necrotizing enterocolitis. Okay, so what happens is that you've got a problem with what? In the gut. All right, so you're going to observe vital signs, of course. You're going to include in your vital signs with this baby, you're going to measure the abdomen. And always, 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 you're listening for bowel sounds. Carefully resuming fluids as ordered. You're going to be very, very careful. Do a strict INOs and maintain infection prevention and control techniques. Surgical removal of that necrosed bowel, it might have to be done. Again, how are you going to take care of this baby? You got to be very careful with this baby. Okay. Now, gavage feedings, you may see a little picture here in your book about gavage feedings. And sometimes infants, they don't have that reflex sucking or swallow, well, sucking. And so they can't take in the bottle, then you would have to put a tube. All right. Now, how does mom and dad deal with a preterm? Because don't forget, neonatal ICU is not cheap, so they need help. It's very upsetting to parents to see the little baby with all kinds of tubes. Imagine, and so you have to explain to the parents what's going on. Yeah, and because it's parents are scared sometimes because of their the baby is so small. Okay, especially if your baby's born at 25 weeks, 26 weeks, they're really, really tiny, and they sound like a little, when they cry, like a little cat. It's so different. And I hope you got to see that film I put on about Griffin, and that's typical of a preterm baby. Okay, so what are you going to do for parents? Well, they need guidance throughout their baby's hospitalization. Parents may also blame themselves. What did I do wrong? Maybe I shouldn't have done this. Maybe I should have taken that extra vitamin. They do blame themselves for the infant's condition. You have to be reassuring to them that, and explain to them why. If the placenta previa was the cause, you explain to them what happened, what the placenta was. If abruptio placentae was the cause, you have to explain. Again, just explain to them what happened. And then parents, again, they're just concerned about a little small person that they got to take care of. And it is scary. Okay. And another question could be on HESI. I know I've seen this one. It's about overstimulation to the premature baby. Because preemies, they use their glucose up quite fast. Remember, we just went over that. So and they use glucose for energy. And it takes a lot for them to breathe. So they're using the glucose to breathe for energy to breathe. Okay. Now, when mom touches baby, though it's wonderful, but we don't want to overstimulate them because then they could tire the baby out, okay, and cause them to have hypoglycemic. I hope you can now see that big picture of how one thing affects the other. Okay, and the best I love to see is what we call the kangaroo, where you put the baby skin to skin with either mom or dad, and they're in the NICU. There's usually a nice little rocker, and the parents can sit right there. Okay, we talked about thermoregulation already. And what thermoregulation is maintaining body temperature, a stable body temperature. So a stable body temperature is essential to survival and management of preterm infants. It's important for the nurse to know how to use various types of incubators and radiant warmers in the hospital settings, so that they provide safe care. And again, we don't want to overheat the baby, okay, and we don't want to have the baby cold. So I use a skin probe in order that I can hook that right up, and it presses right into the radiant warmer, and it gives me the body temperature of the infant. So it works really well. And sometimes with gavage feedings, you have to be very careful. You want to observe and record bowel sounds. I want to always record whatever baby puts out. And for gavage feedings, an aspiration of gastric contents prior to feeding is important. Yeah. And if no residuals received, then it's safe to start the feeding. So what that means that there's nothing left from the previous feeding there. That's what we call residual. So if there's nothing there, are we safe to give the baby some more? Yeah, then we are. Okay. Now, if you get a residual, if there are some liquid contents, then you want to call the doctor, and you want to let them know that how many mLs of residual I got before I proceed to feed the infant. Because I don't want to like overfeed this baby, because these babies have a slower time of metabolizing everything. So again, I want to be very careful with the gavage feeding baby. And I want to make sure that I am listening to bowel sounds. Because if I don't have bowel sounds, I need to report that. All right. Okay. Now, how you going to position and do nursing care? Well, preterm infants are placed on the side or prone with the head of mattress, slightly elevated, decreased respiratory effort. It improves oxygenation. I like the baby on his back with the head of the bed slightly elevated. I go with that one, or the side with the head slightly elevated. I don't do prone. And I have the mattress slightly elevated to decrease respiratory effort. It makes the baby easy to breathe. Just like if you were laying in your bed and you had shortness of breath or you have congestive heart failure, what's a good position for a patient with congestive heart failure? The head of the bed up, right? Same thing, same thing. If you have, then you can have improved oxygenation that way. Okay. And by doing this, you're organizing this baby's sleep pattern and it lessens physical activity that burns up energy, which is needed for growth and development. I want to conserve this baby's energy, because a baby is growing and he needs energy to grow and to develop. So I want to make that his respiratory is made easier and he gets more oxygen, which he gets more red blood cells, right? So it's better for growth and development. I hope you're seeing this connection. And then as again, also compatible with drainage of secretions and prevention of aspiration. And always, 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 you don't leave the infant in one position for a long period of time because it increases the risk of skin breakdown. Infants can have skin breakdown just like a geriatric patient has skin breakdown. Okay, so again, that is on your pretermer. Now I'm going to head over to your post-term, and you know the definition of post-term is a baby born what? Beyond 42 weeks gestation. I would know that, okay, because you know what the difference was. We went over the definitions of post-term, preterm, full term, late term. So you know those. So post-term, he's born beyond what, 42 weeks gestation. Remember, the placenta does not function well after a certain point. We talked about that the placenta gets old and gets calcified, so it decreases then the blood circulating and therefore decreases oxygenation to the baby. Okay, that's why I told you, remember, if I have a 42-weeker in labor, I'm going to be watching my fetal monitoring very, very close, like I always do anyway, but even more so, because why? Because I have to worry about the placenta not giving enough oxygen to the baby. And of course, if you have late decelerations, late decelerations are caused by uterine placenta insufficiency, and you can have what heads into fetal distress. All right. And mortality rate of later term infants is higher than that of term infants. Yeah, and I already told you my story about my patient. All right. So what kind of problems associated with a post-term delivery? Well, you have meconium aspiration, and we talked about. You have asphyxia, poor nutritional status, increase in red blood cell production, difficulty delivery because of increased size of fetus. Yeah, you can have CPD, cephalopelvic disproportion. You can have shoulder dystocia. Those are all kind of problems that can happen. You have birth defects, and you have seizures. Not good. So physical characteristics of the post-term newborn. Well, usually when they get to a point that they're not growing anymore, they can look like they've actually some weight could have been lost. The skin is loose, especially around the buttocks and thighs. There's little hair or vernix caseosa because it's all used up. Then the skin is dry, it gets cracked and it peels. And then you have the nails, they're long, and they may be stained with meconium because the baby's been in there a long time and gets underneath their nails. And then you have some areas that need to be looked at. They just look like they've been in there just a little bit too long, okay? That's with their skin. So that's about the postpartum. Now, if you have a baby that needs to be transported from a low risk hospital, like a level 1, to a high risk level 3, you may have to transport these risk babies. Now, postpartum has it just as bad as preemies. And they may not be breathing very well, so you may have to transport them. So what we're going to do is we always want to stabilize the newborn before we transport. Always. You always get a baseline, such as vital signs and blood work. Always get that. And we give that all to the transport team. Oh, yeah. And I copy all the medical records, mom's medical records, and the labor and delivery report, and then include the mother's prenatal history. So I make sure that everything is entered into the electronic medical record and is all to date, everything she needs, everything. Because once that baby's transported to another facility, that I want them to have a clear picture of what happened. And so, and the type of delivery, so important. So that's on that labor and delivery report, and it goes over all that. Also, before I let that baby out of my sight, I'm going to band the baby. I always band my babies, and it's essential that the babies are banned in the labor room before it's being, excuse me, taken to even the NICU. So we usually have one nurse that will write the bands up real quick, and they just have to plug in, like, male, female, and the time of birth, and we have everything else on there pre-done, and so that we have everybody with the same identification number band. Okay. I bring the transport incubator to mom's room before we let the baby go to another facility. Of course, you get consent forms, and we give mom all the phone numbers to the transport hospital, like the new, I say Arnold Palmer, that they're going to go to, Florida Hospital, Advent Health, that they're going to go to before, so they know where the baby's going. And we always take a picture. Yeah, take a picture and give it to the parents. All right. It's not easy. I've had to do it several times, and it's just not easy. Moms get, they just had a baby, and now their baby has to go to another hospital. The ultimate thing to do is to transport mom to that higher level institution. But sometimes she's comes in quite dilated, and we can't transport mom. It's too dangerous. So what we do is then we just transport baby. Okay. So what is the nurse's role in the discharge process of a high-risk newborn? Well, you have to make sure that the parents, you give them, education, and they need to demonstrate to you and the specialized care, especially if they're going to go home and they're on an apnea monitor, or they've got gavage feeder. Make sure that they're all have the education to do this, and they have to demonstrate it back to you. And a lot of times too, we'll do home visits. They have home nursing care. And you have to go over the newborn's behavioral pattern, and realistic expectations are reviewed, okay? You should teach them newborn CPR, okay? And make sure they have like support group referrals, and some social services is another thing I would have on my team, so that they can ensure that the home environment is satisfactory and the special needs of the infant can be met. Okay. And then we have what we call, these are called warm lines, warm, W-A-R-M lines, L-I-N-E-S. And what that is, that's a telephone line between the hospital and the parent that went home with the special care needs infant. And so they know that they're not alone in this. Okay, it's very important for the parents because remember, that's one of the things that parents get really nervous about is that they don't know how to take care of these babies. Okay, well now that ends this chapter. That was chapter 13 on the preterm and postterm newborn. And so there was a question even on the quiz about surfactant. So you probably, if you don't remember surfactant, then you need to go over that. So let me just go over this with you. The production of surfactant is necessary for the absorption of oxygen by the lungs. Now, in preterm infants, surfactant is deficient, is low. So respiratory distress syndrome, or RDS, also called, I think you heard me say this term, hyaline membrane disease. That's an older term. This is a result of immature lungs, and that leads to reduced gas exchange. So what we can do is we can give mom who's in preterm labor 2 injections of surfactant. It's a steroid, and what it does, it stirs that the production up quicker. Like any steroid, what is it? It increases the production, and so we have to have that. It's like, remember I told you, it's like the lubrication, the lungs. Okay, so we give mom that injection, 2 injections, 12 milligrams IM, 24 hours apart, and that increases that surfactant. Because if a baby is deficient surfactant, you can have respiratory distress. Okay, it's not good. So be sure that you go over that a little bit more too if you're having a problem with that. Another area I saw that was kind of low on was cold stress in the baby. Cold stress. Okay, well, what would you see if you had cold stress in a baby? Well, remember, signs and symptoms of cold stress include what? Mottling, M-O-T-T-L-I-N-G, of the skin. Kind of gets that appearance, like cyanotic looking appearance. Lethargic, decreased skin temperature. Yeah, if you got cold stress, that means that your baby's body temperature is what? Low, not high, low. So that's not good. Then, because my baby's temperature is so low, he's breathing fast. So now you have tachypnea, breathing faster than it should. And because of that little thing, he can get apnea. He can get so tired, he goes, okay, that's it. Oh, gotta breathe again. Okay. And then bradycardia, his low heart rate will go down. So be sure that you go over the findings that would be associated with cold stress. Okay. And you know, meibomian spots, they are the bluish discoloration of the skin. And what happens is that they will fade eventually, but you know, there is no like cream to remove the discolored spots on the baby's bottom. No, they haven't come up with that yet. So it does, they disappear spontaneously during the early years of life. Okay, so you have to be careful to differentiate the Mongolian spots from what? Hematomas that come up from maybe a child being abused. So a lot of times when they come in to the ER, we have to be very careful about that. I would go over the port wine stain. That's also known as the nevus flammaris. That's nevus, N-E-V-U-S, and the next word is flammaris, F-L-A-M-M-E-U-S. And what that is a collection of capillaries in the skin. Okay, it is flat, is red purple lesion. that does not blanch on pressure. And I know in your book it has a really nice chart. It has a picture of all these. And then you have the nevi, N-E-V-I, that's known as stork bite, or it's pink, is easily blanched patches that can appear on the eyelids, nose, and lips, and the nape, N-A-P-E, of the neck. Okay. So make sure that you kind of go over those two. But you know, there is no magic to take away the Mongolian spots. Babies are born, especially if they're born to mommies of African American, Native American, and the Mediterranean descent. Okay. All right. Alrighty, and we talked about meconium aspiration, we talked about NAS, we talked about gestational diabetes, we talked about cleft lip and cleft palate. One of the things, the nurse's priority would be what? Nutrition. We talked about that already. I talked about the test used to confirm Down syndrome, which is an amniocentesis. All right, so we kind of went over all this morning. So make sure that you know what I talked about. Depressed fontanelles associated with what? Dehydration. We talked about sweet smelling urine. Circumcision. If you don't remember the care of baby born with circumcision, go over circumcision care. Okay. The proper use of a bowl syringe. We went over acrocyanosis. Okay. We went over bronchial pulmonary dysplasia. I think you'll be fine. These are things, everything I have gone over with you in all the different reviews. And what are you going to do when you're on the test on Tuesday? You're going to take your time. You have 75 minutes. There is no need to rush. And read the questions carefully. Sometimes it's in the reading of the question, like the word contraindicated. Or another big one is the nurse is assessing maybe the learning ability of the patient, and which of the following would be needed for further teaching. Which one? So that means that whatever answer is not correct, right? Because the patient needs further teaching. So 3 of them would be correct and 1 is not. That means I would have to teach that mom a little bit more. That's what that means. So just read. Don't read into the question. Like you see something with maybe meconium aspiration syndrome. You go, oh, I know that. Yeah. And you just jump. No, you stop. And you ask yourself, what's the question asking me about meconium aspiration syndrome? Because those are things that students jump. And because they oh, I know it. But that's not what the question's asking you. Okay. And that's how questions are. I mean, we give you explanation of raw material, but then the question may be like total opposite. You know what I mean? So you want to make sure that you read the question. Honestly, that's the biggest problem, is that nobody takes the time to really read the questions. Alrighty. Well, thank you very much for attending today. And I'll post this eventually under announcements or in inbox, wherever my Zoom Canvas will take my Zoom. But you all have a wonderful day, and kudos to you that did attend.
Thank you.
You're welcome. Have a great day. Okay.
You too. Okay, bye.
Bye.